box, that we'll be recording the session, and please do use the chat box freely throughout, and please use it now just to introduce yourselves in the chat box. It's lovely. Let's see who we've got. So great. So brilliant. Right. Thank you very much. We've approached 1 o'clock. I think we'll give people another 30 seconds or so. Lovely, lovely to see people introducing themselves. Thank you so much for doing that. That's lovely. Oh, a good mix of people starting to join. That's great. Got 22 people. I think we should perhaps make a gentle start, shall we? That's absolutely great. So I'll start with my introduction. My name is Nikki McNaney. I'm one of the directors at NHS Elect, and we've got the absolute privilege of working alongside Avi and Suki and colleagues with CPLG about looking at clinical and care professional leadership across Derby and Derbyshire, and with helping support this pulse check, which is to find out how things have been going to date and think about the next 12 months ahead. So Suki, if you move on the slides, we're going to do a bit of a Chris Whitty to start with until I share. So that's brilliant. So thank you. So we're going to give a little bit of brief context around this, and I'm going to pass over to Avi in a minute to start that. So we're going to share the ambition and journey for clinical and care professional leadership for the ICS in and joined up care in Derbyshire. We're going to find out how much you know about the work and the work together, and we'll do a quick Slido so that get your cameras, your phones and on camera, or to read a QR code ready for that after we've done some introductions. We want to answer your questions and then find out how we help connect and collaborate across the ICS. So we'll be working in that space. We've got plenty of time for you to ask and comment. We've got a couple of key questions to ask you, and so we hope it'll be quite an interactive session. And as I say, I've got a Slido, but please do keep using the chat box throughout. And any newcomers, do introduce yourselves. Can people hear me okay? So we've got comments in the chat box. So I'm sorry, Claire, I think it may be you, not me there. I've got the thumbs up. So I'm really sorry about that, but hopefully you can follow us until you can get your sound sorted. So just a quick reminder from me that we are recording the session, and I'll hand over to Abby and Suki to introduce themselves, and Abby to set some context and Suki to talk you through the journey. So over to you, Abby and Suki.
Thanks, Nikki. Hi, I'm Avi Barty. I'm GP in Long Eaton and chair of CPLG. I'll just cover a couple of bits about introduction and then go from there. Firstly, and most importantly, thank you for coming. And thank you for taking the time. We know how busy everybody is, so just having an hour here of your time is very, very much appreciated. CPL, and forgive me if I'm pitching some of this that you already know, and forgive me if there's bits that you don't know, please just ask, because I can see there's a broad breadth of people here, some members of CPLG, which is fantastic. The CPLG is the Clinical and Professional Leadership Group of the Joined Up Care Derbyshire, or the system, or the ICS, however you want to refer to it. And the group itself is made up of senior clinical leads in all organisations. So that's often the medical director and the CNO. We have representation from general practice, but also from optometry, dentistry, pharmacy, and also social care as well. Hence clinical and professional leadership, not just clinical leadership. And you'll also see the term CCPL, lots of acronyms, I'm afraid. CCPL is Clinical and Care Professional Leadership, which is the concept that we're trying to deliver with this. So as part of that, the CPLG is a formal group that meets on a monthly basis. It has agenda items that deal from NHS aspects to wider ICP aspects to developmental aspects, and it has a membership, as I've annotated, which we can share with you quite easily. The concept is wider than that, though, and we're hoping the concept is around how the clinical and professional leads in each of the organisations within the Derbyshire system can also work together, and how we can try and join that up as best we can. You're probably all wondering, or you may be wondering, why you're here or why you've been invited to this. So one of the things we did with the CPLG was to ask each organisation in the Derbyshire system who were the clinical and professional leads within their organisation. So who was doing some clinical professional leadership work of any aspect, so that we could get an idea of across the system, not just within the ICB, etc., of who was doing that work. And the idea behind that is that we could sort of, as a organisation that's system-wide, see if we could try and map who was working, and in a very simplistic way, how we could possibly join them up. So you'll hear me use this phrase a lot. The right hand knew what the left hand was doing, as is often not the case within a large system. And you will have all been identified, I hope correctly, by your organisations as leads in this area, hence the invite to this. There'll be some of you who might know quite a lot about this concept. There are some of you who might be thinking, who the hell is he? What's CPLG and what's CCPL? All of that is absolutely fine. And I hope we can answer some of those questions today. That's one of the reasons of this group. The CPLG group that meets on a monthly basis is fed into by various other groups. And I won't share thousands of acronyms, but we can forward some of the governance structures around that. And we want that group to be fed into by others as well, because the whole idea is that's a system clinical group. And if there is a degree of agreement and solidarity in how the system clinically wants to do something, usually that gives a lot more strength, as opposed to it happening in silos. And the CPLG group therefore sort of, I wouldn't say infiltrates, but sits on some of the other groups within the system. So we have representation on the ICB board, we have representation on the ICP, at a group within the ICB, which is the PHSCC, which is often associated with how resources are allocated, also within PLACE, through some of the vice chairs, and also within the provider collaborative leadership board. So sort of the influence of that group, which is made up of individuals, but also all of us, hopefully can bore out in the system. One of the things that we probably have frustrations with in the system in terms of clinical leadership, and I'm sure this might be shared by you, and we can't fix everything, but we can try and look at this, and this might be something we discuss today, is duplication. So how these bits of work can be duplicated and two sets of organisations doing the same thing, which is probably not ideal. Which is actually, if there is any clinical work or pathway work or aspects where there's clinical or professional input into, how is that got off the ground? How is that funded? Who would you talk to get that done? And crucially, how will you have conversations with people in different organisations? I'm sure you're all quite well set up with how those organisations work within your own organisations, but actually, how do they work if, for example, a trust wants to talk to general practice, or social care wants to talk to general practice? And how can we oil those wheels and facilitate and help that connect? And crucially, the last thing I really want to say is this is all evolutionary. So none of this is a finished product. None of this is perfect in any way, shape, or form. We are just trying to build something as best we can, which is trying to bring together the clinicians and professionals within the group, within the system, to see how they can best exert their knowledge, influence, and ability to get things off the ground, and see how we can help them to do that going forwards. And we'd be very interested to know your views, because for some of you, this might be the first time that we've actually managed to reach out to you and have these discussions. And the more we can get to know who everybody is and how everybody works and how they interact, the better we'll have this system going forwards. I was promised to only do a couple of minutes, so I'll be quiet now. I'll now hand over to Suki, who'll take you through a few slides. Again, apologies if some of you already know this, but we have to sort of pitch it so that everybody gets a sort of a baseline of a shared understanding. Suki.
Thanks, Avi. So building on Avi's helpful introduction there, again, there are varied, there's varied representation here today. Some of you have been part of this journey with us, which we commenced, I'd say, in earnest about 18 months ago. So we began the journey, and as Avi says, it's an evolution, it is iterative. Whereby we started to develop our clinical and professional leadership framework for the system, which was done in consultation with multiple groups, individuals. At every level, we tried to reach out and use some of those system groups that are in existence, but also we had a couple of broader clinical and professional leadership engagement events where we actually got, a raft of views to help shape our vision for what we wanted the Joined Up Care Derbyshire clinical and professional leadership vision to look like. I won't read it verbatim, but the key components of that were about kind of having everybody has the opportunity to be involved, is informed, and has the ability and opportunity to influence and lead decision making at all levels. And I think that bit is really important because what we're trying to avoid is that system, just because you're identified as a system leader doesn't mean to say you're not doing things at the very front line and making decisions to influence and impact on, the health of our population in a leadership capacity. So that was one of the things that I'll come on to in the next slide around that distributed leadership model. But within all of that vision, it's about how we are, supported by trusted and connected leadership. So one of the strong themes that really came out of the work that we were doing was about how do we better connect? And that links to Avi's point around the duplication. How do we avoid some of that siloed working so that we're working together with the same goal and ambition? So on the back of the vision, we did derive, and we will share the slides after the session. We did come up with a set of underpinning principles as to how each and every one of us, irrespective of what level we are working at within the system, there are guiding principles as to how we operate as clinical and professional leaders in this space. How do we all act as ambassadors? We make sure that we're communicating with one another and effectively having that meaningful dialogue. We're facilitating that broader clinical and professional leadership that's connected and representative. And that one's a really important one for me because often we fall into the trap of it becoming very NHSE, very clinically led, and actually it's about broader professional representation and leadership as well. And actually the richness comes from all of the different perspectives coming into that. So as I say, I won't read all of these, but it is about that informing, influencing, reducing the duplication, and we value everyone's contribution. That's a really important principle, that everybody has an equal voice, irrespective of whether you're a medic, a nurse or a social care worker. Everyone has an equal and valid contribution and will be heard within the space. We've got to listen to each other and respect one another. So on the back of that, we designed this is our leadership model. It is a distributed leadership model. So as I say, it isn't about everybody just working at a system level, at the top level, at board meeting levels. It is irrespective of where you are, it's how you connect and what we call the workings of the ICS. And the governance is complicated. It's really hard to navigate. So it's how we help one another to kind of find that. And the orange circle in the middle, the group that Avi referred to, we see that as the strategic group that sort of binds all of this together and facilitates and enables everybody to have that voice at whichever level and helps to overcome some of the barriers that we've been facing. Now, some of it will be, working at system level, organisational level, but frontline leaders within their own space, how they operate as leaders as well. But I would also say it's pan-Derbyshire as well, beyond the Derbyshire footprint, because there are regional networks that we need to connect to. And how do we do that effectively, but bring that learning and that into the Derbyshire space as well. And it's making that connectivity both vertically and horizontally. So I'm going to pass back to Avi at this point, because this model tries to simplify what started off as our simple version of the model. But Avi, if you just describe how this simplifies that even further.
Yeah, this slightly suspect slide that you can all see in front of you, I will now try and explain, which we came up with last week, and I think sort of might be the concept of what we're trying to talk about. So we've got the system, whether you call it the system, whether you call it Joined Up Care Derbyshire, whether you call it the ICS, they're all sort of synonymous. And within the system, we've clearly got lots of organisations, big organisations, small organisations, sovereign organisations, all sorts of things. And within each one of those, there's clearly clinicians and professionals working, doing leadership work within the organisation for things that organisation needs to do, and some bits that are out of it. What we're trying to do with this Venn diagram is quite, and we've only got 3 organisations here, obviously, but there's far more in Derbyshire. I've tried to simplify it, is to basically say that there are some aspects that are happening within organisation, and that's fine. We don't need to interfere with that, and job done. There are some that a couple of organisations need to come together, might be 2, might be 3, and there are some where the whole system needs to come together. So, for example, the CPLG group, if you can imagine all the organisations are represented, is the bit right in the middle. But there might be some where general practice and a hospital need to come together. And we've had instances in the past where that has not happened as well as we would have liked. And I'm sure you can all think of examples that have happened in your organisations, or crucially, when your organisations have wanted to liaise with someone or somebody else or another organisation in the ICS, that it's not been perfect. Where do I go? How do I get that done? Who do I speak to? Etc. etc. We see it quite a bit. It might have improved immaculately, and you might say, actually, it's already perfect, leave it alone. But what we want to try and do is see how we can help without interfering, bringing some things together formally right in the middle where all organisations are aware. So there is a clear system, clinical and professional view or opinion on something. And also, if we can help with bits that are just between a couple of organisations. And some of this is also around actually empowerment and actually saying, please get on with it. And we do have a governance model around this that's been endorsed by all aspects of the ICS, which does say that there are certain things that actually you don't need to bog yourself down with too much governance to get that done. And so it's almost like a reference point, or the whole CPLG and CCPL concept is contained within. I hope that makes some sense. It's massively simplified, but what we're trying to do is to sort of say there is work going on within, there's work that's going on system-wide, and it's particularly the system-wide work that we want to try and help support, but make sure that one organisation has sight of who's in another, purely when some help might be needed or something needs to be got off the ground. I'll go back to you, Stevie.
Thanks, Avi. So there's a lot of content in this slide, so I won't go through this. But again, as part of the work that we were doing, we identified some development themes as part of our framework development. So the first one was about having a clear model and narrative, and I think we've covered that, and that was something that was endorsed and supported through those wider clinical and professional leadership events. Everyone was clear that it wasn't about all roads leading back to a group to do everything. It had to be about distributed leadership. So we needed to make sure that we strengthen that approach going forward. Very strong themes around diversity and inclusivity, and making sure that we have the right mechanisms to ensure that we've got the broadest engagement across the system. So these are some of the things that we committed to doing and continuing to develop. The leadership roles, having clarity of purpose, but also, having the support to be able to do that around leadership development, nurtured by having those leadership opportunities, not just formal leadership opportunities, but those opportunities to connect as well. And again, comms and engagement was a very strong theme that came out of that framework development, around really making sure that we are all understanding the journey that we're on. And fundamentally, one of the things was around the role of CPLG as a group itself and what that needs to do to support the whole process. So what do we actually mean by distributed leadership? And we've kind of used the Richard Bolden definition because actually it fits nicely with everything that was all the emerging themes that we were finding through our discussions. Essentially, and it links back to that Venn diagram that Avi's just described around leadership responsibility being disassociated from formal organisational roles. It's you may have heard people refer to about taking your badge off at the door, and you know we often have said that in Joined Up Care Derbyshire previously about you're part of a system. It doesn't matter which organisation you work for. And the influence of people at all levels is recognised as integral to the overall direction and functioning of the organisation, and in this case, it's of the system. But it has that system-wide perspective, and it not only transcends at organisational levels and roles, but it cuts across those organisational boundaries. So I think that articulates the Venn diagram that Avi's just described really well. So the next thing we did as part of those early engagement sessions is, what do we actually mean by system leadership? What are the behaviours that we're trying to articulate and demonstrate and enact in each when we're just talking about system leadership? And it was just kind of this flower, we call it a flower diagram. I don't think it looks necessarily like a flower, but that's the nearest thing that we could describe. But it's that bit around kind of things that are inside boundaries, but also across and outside boundaries, and separating out some of the tasks and processes. But essentially, it's about clarifying and the ways of thinking and doing. What is it that we're trying to do? How do we think differently? How do we actually do the real work together? Co-creating so that we're doing it with one another, that we feel and perceive things. We recognise the unseen and unprecedented. We seek those diverse views and understanding in how we operate, but also the conditions and the ways of being, having the courage to take those risks. We're enabling one another, not only kind of always looking upwards, but we're helping one another to kind of move and remove some of those boundaries, but within that being accountable to do that as well. And that might be within the organisation, across the system as well. And then connecting with one another. It's that ways of relating, so that we are well networked, but we've also got those weak ties where we're not actually necessarily as strong as we could be, but we recognise those, and how do we build on those as well. And again, as I've said previously, that mutuality, the respect and understanding is really important to get us to work in that same direction as well. So that was one of the things that actually came out of those engagement sessions and was designed with colleagues through those discussions and further tested with them as well. So I think I'm past. Oh, sorry, Nikki, I'm back to you now.
Indeed. So thank you. Thank you very much, Suki and Avi, for setting the scene. And there's lots of opportunity in a minute or two to start to ask some questions. And then we've got a couple of questions we'd like to pose to you. So for anybody that's joined us, welcome you to this session. It's lovely to see so many here. And I'm Nikki from NHS Elect, and I'm just here to make sure that the conversations go really well and that we hear everybody's voices. And I've been doing that quite a lot across a lot of system groups, including the central group that CPLG, the Clinical and Care Professional Leadership Group that Avi mentioned, so that we're starting to say what's great about the work to date and where do we need to go for the next few months. So we've got a little bit of a poll for you now while you're thinking about your questions, and it's really asking you about this story, this journey around clinical and care professional leadership from its very early genesis as part of the transition to ICSs and ICBs, to how that's been owned and taken forward in the Derby and Derbyshire system. So if you've not used Slido before, if you open your camera, brilliant, some people do, and you aim it at the QR code, it'll take you to Slido and allow you to answer this question. You can use the QR reader, your camera, or you can log on at slido.com and it will ask you for the session detail, which is #201896. And we'll just see if we can get as many as you as possible. There were 40 something people before I lost the screen share there. And let's see how this settles down and just how much of that story did you know, because this is the first really insightful thing that we can see. So biggest vote for none. We've got about half of you taking part at the moment. See if we can get some more of you to just let us know that. We'll try and get at least 30 of you saying what you knew while you're thinking of your questions. 27, great. So it's mostly none, some very little, and very small number that knew the majority of that. So some really useful context setting and introduction. I'm sure you'll have some questions for Avi and for Suki in a moment or two. I'm just going to leave the poll open a little bit longer. Yeah, of course you can. Please do.
Just for everybody, I'm in a way very glad that, well, I'm not glad. I'm hoping we pitched this at the right individuals then. So there's no issue at all with people knowing none. That's the whole idea of this session. I suppose what I'd probably like to know in the chat box and perhaps in the questions is, has what we've just gone on about for the past 20 minutes helped? Or has it just created yet more confusion? I know that's not a Slido question, but I would be interested perhaps just to stick it in the chat box of helped, not helped, or how we could better get this narrative across, if you see what I mean. Nikki's probably going to ask that anyway, and I've interfered for no reason. I'll shut up.
It's sort of like the first question, but a little bit different, Avi. So I've got no problem with that at all. And thank you for saying that there's no problem to know none of this. I'm going to just close the poll now. Let me just keep it active so I can download the results. And I think, Suki, you've got a slide now that, let me just stop sharing that so you can't all see yourself. Thanks, Damien, thanks. Okay, brilliant. So Suki, you're going to just put the slide up that asks people, that invites people to pose their questions. We don't need all this context, but when you introduce yourself, say a little bit about who you are and what you already know and how you're connected in the system, which organisation, and if you're perhaps working on pieces of work that cross those boundaries that Avi mentioned. So hands up in the usual manner, and questions in the chat box as well. We'll try and watch that as well, and Suki will help me with that. So I've just got the chat box open. So who wants to ask some questions? David, you are first up, please, coming in.
I always want to ask questions. Thank you.
Good.
I was just wondering what the context for this would be, because I can see how distributed leadership model starts to frame how our approach, but some of the difficulties are maybe around the primary care secondary care interface. So if it was going to be applied to that, then I could see how that would be helpful. The other thing is, kind of what is currently the reality of working in the NHS as it is today. Are we all feeling safe in terms of the jobs that we do? And so how could this model help to support that? So as system leaders, I mean, I was constantly worried that I become a leader and then I become detached from the people at the coalface, which is where the reality of the care is being delivered. So if this was a nurse on a ward, or someone, would they recognise that this distributed leadership model was in operation and that was a reality of the day-to-day working practice?
Brilliant. Great questions there. Suki, I know you want to come in. Should we just, do you want to go first and then we'll go over to Avi? That'd be great.
Yeah, it was just sharing my thoughts on that one in terms of just reflecting on a couple of the engagement sessions that we held, and colleagues that we'd invited to come and speak about their leadership experience and journey. And there was one when I approached the individual, she said, I don't see myself as a leader. So I said, talk to me about that. What do you actually do? And she said, well, I did this and I worked across the boundary and I did this. I said, that there is leadership. And they were very much at the coalface, that point that you've just made around, it becomes detached. I think it's about the recognition that what they're doing at that point is actually they are leading and they are actually enacting that leadership role. They don't have to be working across the system, or they might not perceive themselves as working across the system. And I think that's the bit that we need to overcome in this kind of journey that we're on. It's making sure that we don't lose sight of that. So your point is very accurate. It's that understanding to let others know that they're also operating in this space too.
Coming in on that as well.
Thanks, Dave. I think very pertinent questions. I think a lot of the work we've done, if I'm brutally frank, up till now has been quite NHS-y, and a lot of the work we've done has been a primary secondary care interface work. I'm not saying that's correct, but that's what's sort of been thrown at us. The system is obviously very pressured in terms of resources, savings need to be made, demands, and individuals' jobs. I think your point around how does somebody at the coalface know that they're part of the distributed leadership, and how do they interface with this is a really challenging one. On the one hand, as a CPLG group concept, CCPL, we don't want to go interfering in individual organisations. That's not our remit. On the other hand, we are dependent, therefore, on the representatives of those organisations who work within the CPLG and CCPL concept, being able to bring some of those bits across. We had a very good challenge at the last meeting of from EMAS of how do we get the view of a paramedic to the CPLG. We do have allied health professional representation on CPLG. That's quite a broad mix as well. So I think these are things that we are wrestling with. We can't have a meeting of 400 people. So actually, and we'd be more than happy to take, I go back to evolutionary, we'd be more than happy to take suggestion on that going forwards and thoughts. And just while I'm answering, I'm just going to answer, because I think Damien's message in the text is very pertinent around exec. You're quite correct, Damien. I think a bunch of clinicians together, let's be brutally frank, can't get anything done without support from managerial exec, or where resources are spent or allocated. And I think vice versa. Well, I would like to think vice versa. So within the group, we do not have direct exec input. I think one of the ways we're doing at the minute is having influence on where decisions are being made as the group being represented. But there's a lot of work that goes on through the EAFs that I'm sure some of you may or may not be aware of, where there is managerial and director input into that to try and make sure that clinician, exec, director, stroke management try and synergize. But none of this is perfect, and we're trying to develop it. I'll be quiet. David, I don't know if you wanted to come back or
yeah, I did. I mean, sort of, yeah, I share the responsibility as well. It's as much my responsibility as it is anybody else's. It's just, it feels like we've been talking for a long time and the reality is not improving. And it's what we have to ensure is that the reality of the delivery, you know, at the coalface is being represented, and that will be my job as much as anybody else's job. But that must be current and it must be real. Otherwise, we'll end up with culture, which is where we're talking the talk, but actually the delivery at the end of the is just not happening. And that's one of my concerns as a GP that I've witnessed over this latest iteration. So how does it return the reality of the purchaser provider split into integrated care that makes the workers feel safe to be able to go into work to do their job, rather than being working in a deficit with vacancies and agency staff all around them and not feel that that's a safe environment.
Thank you very much for coming back at the back with those comments. Really, really helpful. Avi, thank you for picking up the question in the chat box. Can I go to Gillian? Gillian, do you want to pose your question?
Hi, so maybe I've got a different slant to David. As clinical place lead for Derby City, I've been interacting and interfacing left, right and centre with all sorts of people. So one of the groups I attend is the Community Diagnostic Centre, and we've been coming up with brilliant ideas about how to make things work better. But once we've made, thought about it, I'm then hitting a barrier with the people above us. I don't really know who in this clinical professional is meant to take responsibility for things that maybe we've talked about. Who do I go to implement it on the higher levels? Because the coalface, we do want to make changes. I'm sure the clinical professional leadership group sits in somewhere. The expert advisory forum, I'm sure, is there as well. How can we tell anybody who on the coalface who wants to make things better? How do we get it up to us lot / you lot? That's my question. I know it's very, what do we call it? It's all about the coalface and not about strategy and strategy leadership, but it is where it's all coming from. So. Thanks.
So how do you get above
to,
that glass ceiling, Avi?
I'm going to take that a little bit. Thank you, Julian. I think it's a really valid point. So I don't want to use the word governance, but I think as clinicians we need to talk two languages. There's the language of actually what we want to do and what we think is best for our patients and what we want to do at the coalface. But there's also the language that the NHS statutory bodies and the system speak. And sometimes we might think that's a brilliant idea. Of course, it's a great idea. Give me some money for it. Let's get it going. The reality is it doesn't work exactly like that. So one of the ways in which that can, and we then end up in governance-y things. I think I hope in place with the localism of it, it can happen more swiftly. In a system, it is a little bit more slow. So we have set up almost a clinical pathway model, which we can forward out to you, which might make it a little bit easier to understand. So if there is an idea in place or wheresoever, actually, how do I get some traction on this? Where does it need to go for me to be able to get the right individuals, A, to support me, and B, crucially, to get some resource to be able to do this? So there's quite a clear pathway that we've developed through CPLG to be able to do that. Often it's a couple of organizations coming together, but hopefully it's relatively simple and relatively self-explanatory. I'll be absolutely frank with you. We don't have any resources to allocate, and that's the reality of it. All we can do as clinicians and professionals is influence where the best we can influence, where we think is going to get the most traction, and come with a singular view. I think some of the issues that have occurred is perhaps a couple of clinicians and professionals in one room have thought that's a great idea, and actually when it's gone out wider, it has not deemed to be a great idea. And that's where problems can occur. So actually one way where there's a real strength of this to be able to push it is if there's an idea, let's just say at the coalface, which can be worked up appropriately. We've tried to make, I'm sorry to keep using the word governance, but it's the way the other language works. And it can be worked up appropriately and taken swiftly to the correct places. There's a much better chance of traction. And that's one of the areas in which we hope we can help. We might not always have the answer, but actually we hope we can say, actually, this is what you need to do to try and get that going. But what we can't do is say, here's the money.
No, definitely not. It's about those people doing the work, knowing who to talk to about when they can see how much with integration the work can be done better. Where is that form? Can everybody know about it? Can we have useful ideas that actually get to the next level? I guess that's it. How do we all, doing our jobs, find a way to put those ideas in? Thanks.
We've got one comment from Damien about these biannual strategy meetings, so connecting execs into the groups. And David, you want to come in again? That would be lovely. And then I'll probably close the questions from you and move on to ours, and you'll get a chance at the end. David, I think you're on mute.
Apologies, yeah. my screen came down so I couldn't unmute myself. Apologies, I've always got lots of questions. I'm a GP over in East Staffordshire, so I'm not even from Derbyshire, but we deal with UHDB, so I've been invited along, I guess. Within the context of kind of what are the problems facing us all, there's a backlog in the system. We've got reduced staffing levels. We're moving from the pictures that provide a split in terms of organisational self-interest. You know, kind of part of the reality of our day-to-day is workload shift. You know, that is one of the ways that we get through without being able to align the resources. So it's always be challenging. I'm struggling to think how we can create change and transformation without just looking to move the work into different parts of the system which are already at strain and without the resources to do what it is that they're currently doing. So, for instance, there's so much more that could be done in general practice. But if you try and shift any work into general practice with the resources we've got, I'm not sure that is going to help us. And that's not going to land well. Equally, I know that I'm not sure that there's capacity in the hospital. So I know that we need to start having the conversations. And I was at NHS Confederation meeting last week, and there is an opportunity to take part in a primary care, secondary care interface support from NHS Confederation. And I'm hoping that Derbyshire will put their hands up for that. And I can facilitate a conversation as well if that is needed. But I think these are the challenges that we need to be applying to this conversation, which is a conversation, how we look at restructuring and transforming.
Abby, if you want to come back on that, and then we'll just get a final comment from Damien before we move on to the questions.
I think we need to share the clinical governance model with everybody, because I think it will answer a few of the questions that are here around resources and how exec stroke decision making is integrated into this. Resource reallocation, I mean, it's an interesting one. Is it one that's done by a pseudo commissioner at ICB level? Because we're not supposed to have a commissioner provider split anymore. We're supposed to be a system. Supposed is the word. Or is it one that is done at a provider collaborative leadership level, where providers will talk between themselves with clear representation from both parties as how that resource is split? I think we can see various examples, particularly between primary and secondary care, and also community care, of where resources allocated in different ways and it can be done more sensibly. So do we go back to the ICB and say, you do it all, you police it? Or do we say to the providers, with that clinical steer, that actually, is there a way that you guys can do this and work together? I haven't got the answer, and we're probably in an evolutionary phase between the two. But it doesn't mean that I disagree with what you're saying. But I think I suppose we have to work within the parameters that we can work. So all I'm trying to suggest from this angle is, if we can have a clear, almost clinical and professional view on these things that is coherent, and organisationally or system-wide, we stand a better chance of being able to enact that. Justin, just to come back, I've got quite a few examples of when clinical leadership has had a bearing on funding. We can talk about them afterwards.
Thank you, Abby, and thank you.
We'll
share. Yeah, and we'll share them. And Damien, do you want to come in just one really quick comment, perhaps, and then we'll move on?
Yeah, no, I've got to shoot off to clinic to see some of the referrals that were not bounced from primary care to advice and guidance. I'm just saying that to wind up GP colleagues. So I've got a lot of sympathy for general practice. I really do, despite people might not believe that, but I really do. I've got a lot of GPs in the family. I've got some insight through friends, etc. But we don't understand general practice and secondary care. I completely understand that. I'm absolutely exhausted by the friction between primary and secondary care, and that's no one's fault. It's probably our fault more than it is primary care's fault. I do think it's a job for JUCD. I think that's within the remit. I think we need to get some bilateral, both clinical and managerial discussion. I know you want me to be quick, but just really briefly, the problem from a secondary care perspective is that we're continually layering on more activity in a finite amount of time. So, I would honestly, it's not a small violin here, but GP's workload has exploded. Our clinical administration work, which is DCC, is, without any hyperbole, at least 50% more than it was 2 or 3 years ago. And we have increasing electronic interaction. So we have emails from community pharmacists, we have emails from our services. We have to deal with a lot. We've now got PKB coming on board. And I do think there needs to be a serious attempt by the adults in the room who are much more eloquent and professional than I, and it could be led by JUCD, and we could come to some kind of shared working agreement around just around the edges of administration and referral. Because I personally think we in secondary care should pause vetting. I think it's a luxury that we can't afford at the moment, and we should concentrate more on advice and guidance, for example. But I think JUCD can lead on this. And it was just to say, I really do support colleagues in primary care, and I'll stop wittering on. And I think you've all described a very good way of working. Thank you. It's been very helpful.
Thank you very much, Damien. Really important points in there, and Avi, something we might pick up in the conversations later, perhaps about that brokering and some of those interface issues that have come up in both of those conversations with David and Damien. Shall I move us on to the questions? Suki, if you pop both questions up, I think we'll take them. We'll take them together. So the first one is really about people just inviting some further reflections on the system ambition and the journey to date for clinical and care professional leadership. So anybody that hasn't been able to contribute through asking questions, just to say, you know, what are your thoughts? What are your feelings about that? Pop them in the chat box or pop your hand up. And then what will help you connect and collaborate better in the ICB space? This primary care, secondary care interface seems really an important thing to do. And perhaps Avi, you'll respond to David about the Confed offer or opportunity. So let's take those together, and people can answer either or make further comment that's useful. So who'd like to start us off? Somebody perhaps we haven't heard from before. Any hands going up? So what are you thinking? The ambitions are sensible. There's, you know, trying to get some mechanisms in place to make that a reality, trying to help people at the coalface really see their connection with the work and the work that they're doing in a system space. This notion of distributed leadership, and then the group that are trying to be the glue to hold things together and enable things to happen and get people to connect and get the support in the right places at the right time. Okay. Nobody answering at the moment. Avi, do you want to come in a little bit, or Suki? Suki, I know you've maybe got another. Oh, David. Okay.
I've always got an opinion. I suppose I'm not sure. You know, it depends what it is that we're trying to solve here, and my ambition is to try and solve as much of the difficulty and the dysfunction that we've currently got, and actually that for me does start off with a conversation, which it sounds, you know, about 15 years since I was allowed in a hospital to have a conversation with a consultant, really, and that has been to all of our loss and detriment. You know, there was a time I used to go to Burton and we used to have lunch with the consultants, and that just seems like from a bygone era. But we had people called clinical colleagues, you know, and we could phone them up, and you know, and we did treat them with respect. It feels like that over the last 10 to 15 years, we've lost so much, that what we have are the behaviours around survival and getting through, which is why I referenced the safety. You know, do people feel safe within the space that they're operating when, you know, for the hospital, you know, I'm sending poor referrals in to try and get through the workload, but equally I've got less time because I'm dealing with a backlog, and 1 in 5 of the people I see are waiting to be seen in hospital. So I'm juggling more balls on, you know, in my area to try and help you, and you're getting frustrated with GP sending stuff that shouldn't be sent along over there. But then if we don't have the conversation and we don't try and do something about it, then we're just going to carry on blaming one another rather than working together to try and find a solution, which is why I bring it back to it's to do with resources, you know, that, and unless we link in and have clear ways of showing return on investment and productivity and improved patient care, and unless we've got some mechanisms there, we'll still be at the It will still be the political views which trump all the decision making, really, which is that it's what looks good on the news or in the papers. Anyway, personally.
You're on mute, Nikki.
Sorry, I'm trying not to cough over you because I've got a terrible cold and I'm not managing my on-off button very well, so apologies. So David, you've got an invite from Damien if you bring your own sandwiches. So I'm just going to go to Suki to answer, and then I'll go to Seema's question, if that's all right.
Thanks, Nikki. I don't know whether I can answer it. It's one of those that, again, it's part of the discussion, is that dialogue. But I was just intrigued to say, David, when you say, many years ago, you used to have those one-to-ones. What fundamentally changed? What stopped you from then picking up the phone and having those conversations with colleagues in the way that you used to? Because that conversation shouldn't have stopped. I get the resource allocation and all the rest of it, but was there something that happened or changed that stopped that from happening?
Yeah, it was about in 2008 when payment by result came in, and the more the hospital did, the more it got paid. And so when we were looking at solutions, it was about the solutions for the hospital were growing the hospital. And we suddenly racked up a £15 million overspend. Well, in Burton Hospital, and the chief executive told me that she was going to do that in order to make it work for the hospital, and suddenly all of the resources got consumed. And when we started to have conversations with the consultants, the management said that we were no longer welcome to have conversations with the consultants because it was not in the interests of the commercial arrangements within the hospital. So we stopped having lunch together, literally. So we used to go to the hospital, have talks, presentations, have lunch together. And that was when, if you stop having nice time together, then your relationships then starts to be affected by that. And so the hospital is now full of probably 200 doctors that I can remember some of them from 25 years ago, but the rest of them are all new and I don't really know who they are.
Can I just come back on that one, Nikki, before you go to colleagues? See, I think that's a really important point, because that is about the relationships, the fundamental thing. It's not the hard stuff where you've got a mechanism. Some of it is just that conversation. It is that relationship. And if that's not there, it makes it really hard to do something fundamentally different. So I do think that needs to change. But I would say that, perhaps naively, is now the opportunity to kind of change some of that. It is individuals are responsible, because we're entering a completely different era in terms of the financial challenges that we are facing. So, we know that the trusts don't have the money and they're not in a position where actually it's about generating that income. We've got to change that. And it's how do we support those conversations in the background? It doesn't need to be a massive thing, but if we can start to chip away to influence some of that, then that's a good thing. But I think there is something about, and Nikki, this is one of the things I think would be really helpful in our write-up, to really capture the ability to have that dialogue being really important in everything that we do now as well. Otherwise, we're just not going to change.
I was going to say, if I could just come back on one more thing, Penny Blackwell, is excellent. She leads the ACT conversation. We did try and arrange once to all get together, and none of us could make it. It just, there's so many just couldn't make it because we were all flat out, and there was no time in the day. So it's in this distress that, yes, we need more headspace. We need to spend more time together. But the opportunity to have nice time together just seems to be, I don't know, gone.
Yeah. So some disincentives from the past, some real pressures and time on future. Abby, there's a couple of things you might want to comment on in the chat box, but I'm going to invite Seema in and then Ian, so we get to hear what they have to say. So Seema.
Thank you, Nikki. Afternoon, everyone. Apologies, I joined really late at 1:30. I had another meeting. For those of you who don't know me, just a bit of my background. I'm a local GP in Derby. I'm acute medicine consultant in UHDB. I'm the Deputy Medical Director with DCHS, and I'm the Clinical Commissioner for Respiratory Medicine with ICB, and I'm the Regional SRO for virtual wards. So I work primary, secondary, community and commissioning all together. So I think my understanding of the exam question here is how we can work together efficiently and amicably and with respect for each other. Is that right? Before I move any further.
Yeah, it's Seema, I think that's the tone, the flavour of the conversation that has, in the context of the larger ambitions around clinical and care professional leadership, and are the things that are being done at a system level really supporting some of those generative conversations and connections. Is that fair to say, Avi? He's nodding.
I think there's a few bits. I invite more conversation. I'm conscious of time.
Yeah.
I know we've gone very much down a primary and secondary care discussion here, which is one facet of CPLG.
Yeah.
This whole CCPL concept. And with regard to that, what I would suggest going forwards is the representatives of those organisations might need to have a conversation, be that at ACT, be that where that might be. We can help facilitate that, and that can feed into CPLG. Clearly, that's quite wide. The other bit that I just want to cover off is actually one of those is actually synonymous with how do we bring clinicians and professionals together from different organisations so they can work together for a common collective. But also the second bit of how can we then also influence where those decisions are made and where those resources are allocated, because it's always around who made that decision, where did they make it, and why did they make it? So how can we actually influence that? So it's a bit wider, but I'll shut up and let Seema come in.
Thanks, Seema, and then we'll go to Ian.
Thank you, Avi, for setting the scene. So to your first aspect of primary and secondary, I think sometimes we often forget there is community care as well. So I'd say, primary, secondary, and community care. In terms of working together, as David mentioned, there used to be a utopia which doesn't exist anymore. There was also this feeling that GPs on a Wednesday are in the golf course, which doesn't exist. Being a GP, I know that myself, and I do tell my secondary care colleagues how hard we work in the primary care, and similarly, as Damien mentioned, the secondary care colleagues don't know how primary care works, and primary care colleagues don't know how secondary care works. So probably a bit more networking is required. In terms of the clinical and professional leadership, so again, I think who's made that decision, what's the decision, and how it's made is a very important question, Avi, because I chair the respiratory delivery group for ICB, and obviously we have CRH there, we have UHDB there, we have DCHS there, we have Derby City Council, Derby County Councils, Public Health, or EMAS. So going forwards, I think EVES, the Expert Advisory Forum, somebody's already mentioned in the chat, is probably the right way forward, where the representatives who are chosen by the organizations rather than ICB to make the decisions or to discuss the decisions and take it upwards. So again, here we're talking about the structure of how the decision making can be done in a way which sits well with the Joined Up Care Derbyshire aims, all the 4 aims of Joined Up Care Derbyshire. In terms of governance of how it should be done, obviously, as Damien has alluded to, it eventually does need to go to CPLG and then PHSCC, if I've got my acronym right, followed by the execs in ICB, which again involves all the organizations regionally. There is a lot of work that needs to be done, and I'm sure we all are aware of that. But I've always believed that if we start small and we build it up, that's the best way, rather than doing 2010 things in one go, which I know we're not aiming or trying to do, but that is how I would approach it from what I've understood, Avi. And please correct me if I'm wrong.
Yeah, I think we can share the whole governance. I'm sorry to keep on about governance, but we can definitely share that model of how things would work, and it just gives a little bit of a better understanding. But what I would probably suggest is, if anybody's confused or unsure, come to us and we'll be able to help. That's what we're here for, if I'm brutally frank. But yeah, I agree, Siva. Thank you.
Yeah, Avi, Ian had to go. He's just put a comment in the box about, you know, nice words. We've got an engaged clinical leaders, and he's hearing some frustration. And I just wondered if you wanted to sort of respond to that sort of themes of the conversation and perhaps round us up, because we're in the last minute of the conversation. So.
Well, most importantly, I'd like to thank everybody for coming again, because I know how busy everybody is. Nobody's taken an hour out of the day. I'd like to thank everybody for being engaged in this as well, most importantly. Sometimes frustration is not a bad thing, because it can actually lead to, let's see how we can sort this out. I think primary and secondary care, and I know that's dominated a lot of the conversation today, and it often does, it is a source of frustration for everybody, and I think everybody will have a different slant on it. So I think one of the first steps is to identify it, and then the next steps is to see how we can actually have, I think, as David has quite correctly said, very sensible conversations to see what we can do to try and rectify it. And I think that's all of our responsibility to do that. I don't think that's just something that CPLG could do. We're happy to help, but clearly, I don't want to dwell on just primary and secondary care, but that is clearly an issue, and it dominates a lot of our CPLG discussions, we're aware.
Okay, thank you, Avi. And Suki, if I can just ask you to just go to the final slide. If you want to continue some of these conversations, have some real influence about what's going to go on in the next 12 to 18 months. Thank you for everybody that have taken part. We've captured the notes. We'll get the chat box feedback and pull that in. And we're theming this to say, you know, to really structure a very short workshop at the end of the month about shaping the plan for the next 12 to 18 months. So please do sign up and continue the conversations. You've got Avi and Suki's email addresses, my email address is around, and people can send me stuff if they need to include some more, you know, you've got further reflections or thoughts about this, and we can capture them. So can I add my thanks, and shall I bring us to a close, Avi and Suki, this afternoon? Thank you very much. Avi's going to share the workshop booking. So thank you, everybody, for taking part in some fabulous attendance today. Thank you.